Welcome back, dear students. We were discussing about anemia, and we already seen one nutritional uh, status which is leading to anemia, that is iron deficiency anemia. Is a nutritional deficiency anemia. Now, the second condition which we want to discuss in anemia, the nutritional deficiency anemia, it is megaloblastic anemia. So, you can see in the picture itself, there are certain cells, some cells which is found abnormal, and it is something different than the normal red blood cells. So, what is happening or how it is made, this different type of cells, how it is made, this is the explanation of megaloblastic anemia. So we can see the details. So the megaloblastic anemia, the red blood cell or the red cell precursors are larger than their normoblastic counterpart, have altered DNA to RNA ratio, loose chromatin and asynchrony of nuclear and cytoplasmic maturation. So what is happening here is red cell precursors. So in the erythropoiesis, you might have studied in the previous years, like the stem cell, from stem cell the RBC or all cells are forming, the blood forming or blood cells are forming from the stem cells, and it is the one of the stage, that is a precursor stage. So this, in this precursor stage, what is happening here in the megaloblastic anemia is it will be larger than the other precursor cells, okay, other RBCs in the precursor cell stage. And in this condition there will be some changes which is leading to this abnormal appearance. So there will be alteration in the DNA RNA ratio. According to the normal values, there will be some change in this ratio, DNA RNA ratio. Then loose chromatin can be seen, and asynchrony of nuclear and cytoplasmic maturation. So the maturation will be abnormal, it will be looking larger in size, with DNA RNA ratio mismatch will be there, and there will be loose chromatin. So in the picture you can see the loose chromatin, the cytoplasm and the nucleus is immature. So this is about the megaloblastic anemia. So hope you understood, the precursor cells are abnormal and very larger than the counterpart or the normal other red cell precursors. Then the changes due to deficiency of vitamin B12 and folic acid, and in certain inherited disorders involving both micronutrients. So this condition, megaloblastic anemia, and this abnormal appearance of red cell precursors can be seen usually with deficiency of vitamin B12 and also the folic acid deficiency can lead to this condition, and also in very specific conditions like inherited disorders which is leading to deficiency of these micronutrients. In that condition also we can expect megaloblastic anemia. So this is about the explanation of what is megaloblastic anemia. So this is the appearance of the red blood cell precursors, and it will be abnormal with the counterpart or the normal precursor cells. So regarding the etiology, already we have seen the micronutrient deficiency. So folate deficiency and vitamin B12 deficiency are the common reasons for megaloblastic anemia, but both are clinically different. Even though the name is same, megaloblastic anemia, the patient presentation will be differing. Okay, that we will be discussing later. So regarding the etiology, in infancy and early childhood, the early periods of childhood, we can see the folate deficiency will leads to the megaloblastic anemia, and usually vitamin B12 deficiency can be seen in older children and it leads to megaloblastic anemia. So both folic acid and vitamin B12 deficiencies are leading to megaloblastic anemia, and megaloblastic anemia In infancy and early childhood, it may be due to folate deficiency, and in older children, megaloblastic anemia may be because of vitamin B12 deficiency. Hope you all clear. Next, we can see what is a pathology. That means how this abnormal cells are formed in or along with the normal cells. That is, abnormal red cell precursors, how it is forming and how it become larger in size comparing to the normal cells. Okay, that is about the pathology. Folic acid and vitamin B12 act as coenzymes in the synthesis of nuclear protein and essential for erythropoiesis. So, we know that the cell division happens, and in that the DNA RNA changes are happening, the new synthesis is happening. So, these synthesis of RNA and DNA, it is helped by two coenzymes, that is folic acid and vitamin B12. So during the cell division, RNA DNA synthesis, these coenzymes are helping in the synthesis of cells. So erythropoiesis is acting as during erythropoiesis, these two enzymes are coenzymes are helping in the synthesis of nuclear proteins. So when they are deficient, it leads to abnormal synthesis of nuclear proteins, or it is defecting, or it's causing defect in the erythropoiesis. So it will be characterized by the presence of oval macrocytes. So when these coenzymes are lacking or it is deficient, in that situation there will be oval macrocytes can be seen, and it will be hypersegmented polymorphs in the peripheral blood smear and megaloblast in the bone marrow. So when you are showing the blood picture of the patient, you can see the macrocytes, that is, the cells are large in shape, it will be oval in shape, it's normally oval, and it is oval in here also, and hypersegmented polymorphs in the peripheral blood smear and megaloblast in the bone marrow. So change in the size, change in the shape of the RBC happens. Okay, it becomes oval in shape instead of round. Okay, regarding the deficiency of vitamin B12, so etiology we have seen and the pathology we have seen, and now we can see what are the reasons which leads to vitamin B12 deficiency. So it can be dietary inadequacy, that is vitamin B12 lacking diet is consumed by the child, disease of small intestine resulting in malabsorption, gastritis, gastrectomy, intrinsic factor deficiency because it's help for the absorption of vitamin B12 at intestine. Then mothers who are vitamin B12 deficient, so the feeding mothers, especially breastfeeding mothers who are lacking or deficient with vitamin B12 deficient, because they may be poor vegetarian, because vitamin B12 is more content is found in meat and other non-vegetarian items, and fish tapeworm infestations and selective B12 malabsorption. So these are the reasons or etiological factors of specifically vitamin B12 deficiency. It can be dietary inadequacy, disease of small intestine resulting in a malabsorption, gastritis, gastrectomy, intrinsic factor deficiency, mothers who are vitamin B12 deficient like poor vegetarian mothers, then fish tapeworm infestations and selective vitamin B12 absorption, malabsorption. So these are the deficiency which leads to the vitamin deficiency, vitamin B12 deficiency. And now we can see the clinical features of vitamin B12 megaloblastic anemia. So deficiency because of vitamin B12 when it is leading to megaloblastic anemia, we can see the first picture as clinical manifestations of anemia can be seen. So in the previous classes we have already discussed about the general manifestations of anemia like irritability, dizziness, then pallor, then koilonychia. These all things we have seen in the anemia. So the same manifestations can be seen in a megaloblastic anemia with vitamin B12 deficiency also. And in addition to that, you can monitor or you can find the changes, that is the neurological involvement, which is usually not present with any other type of deficiency states of anemia. That is, neurological involvement can be seen. In that condition, you can see the ataxia, paresthesia of hands and feet, loss of vibration sensation, and absent tendon reflexes. So these indicates there is the involvement of the neurological system, and that is because of vitamin B12 deficiency. So in anemia with megaloblastic anemia, if these manifestations of neurological involvement is seen, then we have to suspect vitamin B12 deficiency. Hope you all clear. Next, we can see how folic acid deficiency happens, what are the etiological factors, and also the clinical manifestations of folic acid deficiency megaloblastic anemia. So, usually it is found along with vitamin C deficiency or iron deficiency. So, usually folic acid deficiency is found as a combination with other deficiency states. Then dietary deficiency of the specific nutrient, folic acid deficiency can be the, and similar to vitamin B12 deficiency, this also can be because of maternal deficiency, especially in a feeding mother. Okay, then use of goat milk for infant feeding, because this goat milk is lacking folic acid. Okay, so in that condition, when we are giving goat milk for weaning, the child may not be getting adequate amount of folic acid through this goat milk. Then malabsorption syndromes can be there, prematurity, diarrheal diseases, association with hemolytic anemia, and drug therapy with anticonvulsant and antifolic acid agents. So if the child is consuming these type of medications also, we can see folic acid deficiency. So hope you all are clear with the etiological factors of megaloblastic anemia of folic acid deficiency. Okay. Now we can see the clinical manifestations of folic acid deficiency. So the pallor, apathy, anorexia. So these all things which already discussed in general anemia manifestations, everything can be seen in here also. Hypotonia and developmental retardation, regression. And some changes which is happening is hyperpigmentation of knuckles, terminal phalanges. So when you're observing the hands and fingers, the knuckles, terminal phalanges will be darkened in color, and there will be fever, repeated infections because of neutropenia. There will be repeated infections, temperature will be the, fever will be the, and bleeding manifestation. Similar to neurological involvement in vitamin B12 deficiency, the change which can be expected here is the bleeding manifestations. So thrombocytopenia will be the mild to moderate enlargement of liver and spleen. Then glossitis, the tongue will be inflamed. That is, glossitis will be the with a smooth red cracked tongue. Okay, so that is strawberry colored tongue can be seen. Strawberry colored tongue can be seen in folic acid deficiency. So bleeding tendencies, tongue discoloration, that is red strawberry colored tongue can be seen in folic acid. In vitamin B12 deficiency, we can expect some amount of neurological involvement. So this is the way how we can differentiate these two conditions even in megaloblastic anemia itself. Okay. Next, we can see the diagnosis: low hemoglobin, macrocytosis, anisocytosis, and poikilocytosis. This is nothing but differences in size and shape. Okay. Then hypersegmented polymorphs on peripheral smear. RBC count will be low. Platelet count, usually it is decreased already. We have seen that it is leading to thrombocytopenia. Total leukocyte count is also frequently reduced. That's why it is leading to repeated infections and fever and other problems. Then serum levels of folate and cobalamin decreased. Schilling test to diagnose intrinsic factor deficiency, so that we are trying to inject a vitamin B12 so that if there is intrinsic factor deficiency, the uh, whole amount will be removed from the body. So based on the elimination and consumption, we will be finding the intrinsic factor deficiency, that is known as Schilling test. So these are the ways how which we will be diagnosing a child with the megaloblastic anemia, and specifically we have to find the manifestations to identify whether it is a vitamin B12 deficiency and folic acid deficiency. So we can proceed to the treatment. So administration of folic acid and vitamin B12, folate and B12, that is a treatment option, because we know that micronutrients are deficient, and the dose of folic acid is 200 to 500 milligram per day for 6 to 8 weeks, and vitamin B12 it is 1000 milligram injection once or two times per week if there is in neurological involvement, because in neurological involvement we have to prevent the complications, so that we may need to inject the medicines. Okay, otherwise we can go for 250 milligram weekly for infants and 500 milligram weekly for older children for 6 to 8 weeks, and concomitant administration of iron and correction of malnutrition is generally required, because usually the micronutrients will be deficient, and along with that other nutrients also may be deficient. So the proper administration of the drugs, iron, and supplementation with a good diet, that is also very important in the treatment of megaloblastic anemia. Also in any nutritional deficiency disorders, we have to manage it properly by correcting the malnutritional status. Okay, so regarding the nursing management, generally for all anemia, how we can give a nursing management. Okay, this is for the previous two classes. Nursing management will be discussed. Like first one is the diagnosis is imbalanced nutrition less than body requirement related to parents' lack of knowledge of age appropriate nutritional needs. So here the child's obtain the child's past and current nutritional history, instruct the caregiver to provide iron fortified formula or supplementary iron fortified foods, suggest intake of liver, dried beans, cream of wheat, iron fortified cereals, apricots, egg yolks, leafy dark green vegetables. Explain the need for iron, vitamin B12 and folate, lack of iron and folate in goat's milk. So this is about the first nursing diagnosis, and interventions are instruct to administer oral supplements as ordered, encourage administration of iron and empty stomach with fruit juice to better absorption, avoid with milk, formula, cereals, etc. Instruct to administer iron through a straw of medicine or dropper placed at the back of the mouth, so that the bad taste can be the problems of bad taste can be intervened, and brush or wipe teeth after administration so that staining can be prevented. Then administer vitamin C for good absorption. So whenever we are administering medicines like iron, folic acid, vitamin C is good for absorption. Next diagnosis is activity intolerance related to imbalance between oxygen supply and demand. Provide periods of activity and rest. Monitor lab values and activity level of the child. Enrich the diet of child with iron, folic acid, vitamin B12, etc. Then risk for injury related to neurological involvement also can be there, because in vitamin B12 deficiency the neurological involvement can lead to some amount of injuries for the child. So these are the nursing management also. So hope you all are very clear regarding anemia. The first topic in hematological disorders and diseases is anemia, and we have seen the classification in detail, and also we have seen two deficiency states like iron deficiency and uh, megaloblastic anemia. Thank you very much. Have a good day.